to a conference.
Thank everyone for joining today's Lunch and Learn on the new 2018 Diabetes Canada Clinical Practice Guidelines. Today's presentation is on the topic of diabetes management in primary care and will be presented by Dr. Richard Phillips, our IH Regional Diabetes Medical Lead. Dr. Richard Phillips is an adult endocrinologist in Kelowna and came to IH in just less than a year ago from Victoria. We are thankful to have Dr. Phillips here with us in the interior region and for providing this presentation today. Prior to starting, just a reminder to please ensure you have your lines muted by pressing *6. And when we open it up for questions at the end, you can press #6 to unmute your line at that time. For your awareness, we will also be recording this session. And with that, I will now pass it over to Dr. Phillips for the presentation.
Well, thanks very much. I call this Lunch and Learn, and be patients all morning, so usually I don't have enough time to have my lunch, so this is more of a learn and blank from my perspective anyway. Anywho, we've had a couple of these things already, and the diabetes guidelines, if you've had a chance to look at them online, quite a lengthy document, and the chapters that I was reading to prepare for today, there were actually 15 chapters that potentially are part of what we're going to be discussing briefly today. So let's see if I can figure out how to work this. So this particular slide presentation was originally put together by Dr. Maureen Clement, so I have to thank her for these slides. They're going to be focused on reducing cardiovascular complications in diabetes within a primary care context. So the organization of care in a primary care context to reduce complications of diabetes is the topic of today. Key not that different from last time, but the importance of individualizing therapy for the person with diabetes, specifically in the setting of hemoglobin A1C, for example. Not everybody needs to have an A1C less than 7. Some individuals would do better with an A1C lower than that. Many people would be better off with an A1C a bit higher than that. So importance of individualizing therapy, not just A1C, but blood pressure targets, etc. Okay, so what's new? There's a lot of things that are new, not a lot of revolutionary things, but a number of things that are worthwhile bringing forward. So one thing you notice when you look at the new guidelines is that they have key messages for the healthcare provider, but also key messages for people with diabetes, because it's not just physicians that are looking at these guidelines, and not just nurses and dietitians, health educators, but also patients are looking at these guidelines. So they wanted to put it in language for people to review these guidelines as well. Of course, reflecting Canada's diversity, especially in the nutrition chapter with culturally appropriate dietary guidelines. They talk about oral health. We know that the importance of oral health is that glucose control contributes to poor oral health, whereas poor oral health leads to hyperglycemia. So it's a vicious cycle off each other. There's new information on trying to differentiate between type 1, type 2, and various forms of monogenic diabetes. Actually, the last time I looked, the maturity onset diabetes of the young classification was all the way up to 13 subtypes. When I was an endocrine fellow, there were only 6. So genetic advances happening rapidly. specific guidelines on driving, which I think will be helpful for primary care physicians, talking about particularly low targets for some people, for blood. The monitoring section, of course, has to take into account the new tools we have, including real-time continuous glucose monitoring, as well as the so-called flash glucose sensor, the Freestyle Libra. And as far as new insulins, guidelines are discussing their role as well, things like Fiasp and Degludec, JO, etc. The DK chapter mentions the issue of euglycemic diabetic ketoacidosis in the setting of ST2 inhibitors, which is a new thing since last time. The in-hospital management guidelines, which we've already, well, actually I think we're going to be doing that in a week, talking about the importance of screening people for diabetes when they're hospitalized, recognizing that a fifth to a third of patients in hospital are going to have diabetes, and some of them haven't diagnosed previously, and some information on post-transplant diabetes as well. So we're not going to be covering all of that stuff, but one of the things with regards to the organization of care, now this has never really been an area of that I'm particularly familiar with, because I'm as an endocrinologist, I'm sort of at one end of the spectrum, seeing only a very small majority of people with diabetes, whereas the vast majority of the management is occurring in primary care physicians' clinics and in diabetes education centers, community centers. So the so-called 5 R's of organizing care for diabetes, other chronic diseases, is something that I must confess I'm not completely up on, but 5 R's as per the guidelines. This particular chapter was co-authored by Dr. Clement in Vernon. So recognize, consider diabetes risk factors for your patients and screen appropriately. So we'll talk about the screening guidelines. Recommending that primary care physicians develop a registry for patients with diabetes so that they can be followed appropriately. Using resources to support self-management, so a very strong language in the guidelines promoting self-management education, so-called self-management support. The primary focus of care is the person with diabetes, and everything else moves out from there. Resources involving all the people on the line today, nurse educators and dietitians, pharmacists, etc. The importance of relaying information between the person with diabetes to the various supporters of the person with diabetes, so that everybody is aware of numbers are, how the person is doing, so that everybody's in the loop to help facilitate care, and having a recall system so that things don't get slip through the cracks, things don't get dropped. Make sure that the person with diabetes is being followed appropriately in a timely manner to identify complications, treat them before things get too far advanced. So these are the so-called 5 R's of organized care, not dissimilar from other paradigms in chronic disease management. This is just the diabetes model. So as far as the recognized aspect of things, the screening recommendations are not different from before. The guidelines are for patients over the age of 40, so 40 and above, screening with a fasting plasma glucose or a hemoglobin A1C every 3 years would be considered appropriate, and starting the screening earlier if patients have a high risk for diabetes based on a number of clinical risk factors. So, beginning with fasting plasma glucose and or hemoglobin A1C. If you have pre-diabetes, then the screening happens more frequently every 3 years, and really not much different than before. The interesting thing about patients that are admitted to hospital, the recommendation is that all patients that are admitted to hospital should have a random glucose performed shortly after admission. And if the random glucose is over 7.8, that they recommend you do hemoglobin A1C. If the hemoglobin A1C is greater than 6.5%, that would be compatible with a diagnosis of diabetes. If it's less than 6.5%, it may be a situation of so-called stress hyperglycemia that will normalize subsequently. But so one can actually use a hospitalization as a means of screening for diabetes. Diabetes diagnosis, no different than previous guidelines, either based on a fasting plasma glucose of over 7, A1C of 6.5%, and can still use a 75-gram glucose tolerance test. That's generally reserved for people who have pre-diabetes on either the fasting or the A1C. So, adding a bit more sensitivity to the diagnosis by doing a 75-gram in those people. Some people will have an artificially high or low A1C if they have an underlying endocrinopathy, and if one is suspicious for diabetes, you can use a glucose based diagnosis either with the fasting or the 75-gram test. So no change in the diagnosis. Of course, a confirmatory test is required on a separate day to confirm diagnosis. No change there. So the rest of the discussion is sort of the alphabet up to diabetes. Dealt with the 5 R's. Now we're going to do the A, B, C, D, E's of disease care. A1, blood pressure, cholesterol, drugs to protect the heart, exercise and eating, screening, smoking, health management. A1, for the majority of people with 2 diabetes, majority of people with type 1 diabetes will be aiming for an A1C of less than 7%. There will be some that you'll be aiming for lower. Certainly young women with type 1 or type 2 diabetes preconception, you want to get their levels below 6.5% preconception if possible. And people newly diagnosed with diabetes, if they can get their A1C below 6.5% safely without inducing hypoglycemia, then by all means aim for that. Of course, glycemia is the major barrier to ideal glucose control, so for most people it will be less than 7. For people who accumulate comorbidities, who become functionally dependent, the A1C targets are relaxed, and when they approach limited life expectancy and frailty, the A1C can be as high as 8.5%. We generally don't recommend A1Cs above 8.5% because then you're dealing with a situation of symptomatic hyperglycemia, which can introduce complications like osmotic dialysis, volume depletion, infections, and just polyuria, polydipsia symptoms. To treatment that's just a little bit different is instead of diagnosing people and saying, if the A1C is 1.5% above the 7% mark, they're saying if your A1C is 0.5% above that individual's target. So, for example, if you have somebody who's newly diagnosed with diabetes who happens to be 82 years old with multiple comorbidities and a limited life expectancy, and their target A1C would be 8.5% or less, and if they're sitting at 6%, then in fact, their A1C is less than 1.5% above target. So you would, be less aggressive with that individual than if it was a 35-year-old with type 2 diabetes with no other comorbidities. So it's starting how to treat these people is based on what their A1C is above that individual's target at the start. Starting, of course, with exercise and weight loss, along with diabetes education for everybody. And if their A1C isn't too high and they're meeting their targets with lifestyle advice, then going to metformin. If their A1C is greater than 1.5% above target, starting with metformin and looking at their response. If they've got polyuria, polydipsia, signs of catabolism, weight loss, visual blurring, then one can start with insulin right from the get-go. Moving right along, interesting, in addition to not the 2013 guidelines, but were added in 2016 as an addendum, was if they're not meeting their glycemic targets on metformin monotherapy, have established cardiovascular disease, the drug of second choice is more clearly delineated in the guidelines. And specifically, they're recommending adding empagliflozin, grade level evidence, or canagliflozin, grade C evidence, based on the EMPA-REG study and the gliflozin study. It'll come to me. Grade level evidence for particularly adding Victoza or liraglutide at this stage as well. These are drugs that not only lower A1C, they lower body weight, but also reduce the 3-point major adverse cardiac event rate and reduce cardiovascular mortality. So that's why these drugs are considered the drug of second choice after metformin, because they not only address the glycemic issues, but they address cardiovascular mortality. If the patient doesn't have cardiovascular disease at baseline and is not meeting their targets with metformin monotherapy, then they're a bit more prescriptive than they were previously. They're suggesting that we should be choosing agents that are not associated with hypoglycemia and preferably are not associated with weight gain. And so the drugs that we're looking at as the second choice in the absence of CAD would be either a DPP-4 inhibitor or a GLT2 inhibitor or a GLP-1 agonist, recognizing that none of those drugs under those circumstances are covered by pharmacare, so cost will be an issue for many patients. An issue, then that's the drug of second choice. So I think we can skip all of that. The other proviso is that when we're dealing with the elderly, we talked about this last week, that generally speaking, DPP-4 inhibitors could be considered an appropriate drug of first or second choice in these folks due to the fact that they are not associated with hypoglycemia, and there is a lot of evidence, randomized control evidence, of their efficacy and safety in the elderly, particularly with reduced GFR. So, for example, linagliptin can be used down to a GFR down to 15 or less, actually. So perfectly safe to use in that setting. The new guidelines, of course, talk about the new insulins that are on the market these days, including the faster-acting insulin aspart or FIASP, which can be particularly helpful in type 1 patients, particularly if they feel the need to take their insulin immediately after eating in order to say accurate matching of insulin to carb intake. So FIASP gives equivalent postprandial glucose control in type 1s who take it immediately after eating as compared to regular Novo Rapid taken prior to the meal. Of course, if type 1 takes fast 15 minutes before a meal, they'll get a small incremental reduction in postprandial control. So sort of an incremental improvements in pharmacokinetics with FIASP. It's not a revolutionary thing, but it's an incremental thing that's worthwhile thinking about. Of course, we have the new basal insulins available to us. Toujeo with insulin glargine U300, Baglar, which is generic Lantus from Eli Lilly, and new insulin degludec, Tresiba in U100 and U200 formulations, ultra long-acting formulation with a half-life of 24 hours and a duration of 42 hours. So very useful in type 1 diabetics who are having nocturnal hypoglycemia despite optimized insulin glargine dosing. So the guidelines discuss that. And we've talked about this already. So clearly in BC, thankfully, if you're a type 1 or a type 2 diabetic and you're going low in the middle of the night on NPH insulin, you can currently get special authority for glargine U100 or Levemir insulin. If you're having problems with nocturnal hypoglycemia despite those two agents, one has the option of considering Toujeo, U300, or insulin degludec. Blood pressure control. They've decided not to change the guidelines from last time with regards to optimal blood pressure in type 2, type 1 diabetics. It's still less than 130/80. It's interesting that the American Diabetes Association did change their blood pressure targets to 140/90 or less. Canada has stuck with 130/80 or less. And they provide their rationale for that in the guidelines. The cholesterol guidelines haven't changed either, recommending aiming for an LDL cholesterol of less than 2, statin therapy in patients over the age of 40 across the board. So a fairly blanket recommendation for statin therapy for all people with diabetes over the age of 40, and starting earlier potentially in people with higher risk levels. I'm getting tired of the sound of my own voice. Does anybody have any questions so far? Can we open it for a minute just in case people want me to for a second?
From Cranbrook, I have a question about the statin replacement. So a lot of our physicians are following the general practitioner guides for statins, and so they only treat secondary prevention. Now, I know the guidelines say primary prevention, but it's really hard to just to recommend guidelines when there's that big difference.
Well, the Canadian, well, I shouldn't say CDA, it's now Diabetes Canada. It's not just the Diabetes Canada guidelines, but it's also the Canadian Cardiovascular Society guidelines from 2016. So they're in cahoots here. Statin therapy is recommended in the Canadian Cardiovascular Society, definitely for secondary prevention, definitely for familial hypercholesterolemia. It's recommended for people with chronic kidney disease, and the fourth, recommendation is for those people with diabetes. So it's considered, for the most part, a cardiovascular disease equivalent. So there is standard approach, from cardiologists as well as the endocrine aspect of things. So not just in secondary prevention, a very strong recognition for primary prevention over 40, especially if one has microvascular complications, including retinopathy or micro or macroalbuminuria. I'm recommending it for all those folks. They're not necessarily taking it. Of course, there's a lot of statin. Some people call them statin deniers, people that are very skeptical about statins, or they're worried about side effects and so on. So you can lead a horse to water, but you can't always make them drink. But I'm certainly at least recommending it and documenting that I've had that discussion. The people that you need to be cautious about are women of childbearing potential, of course. Type 1 women, for example, you want to take them off the statin prior to conception. And before we run, drugs to protect the heart. I thought this was interesting. So the product guidelines, we're essentially saying that if you have a diagnosis of diabetes, you basically should be trying to lower your A1C, and all comers being on a statin and an ACE inhibitor based on the HOPE study. The inhibitor recommendations are a little looser than they were. So certainly is to use an ACE inhibitor such as amipril or perindopril in doses that were shown to be effective in the landmark trials in those people who have established clinical cardiovascular disease. So secondary prevention, ACE inhibitor is part of that. But also in those over the age of 55 with an additional cardiovascular risk factor or evidence for microvascular complications. So if you're over the age of 55 and you've got no other cardiovascular risk factors and no microvascular complications, you don't necessarily need to be on an ACE inhibitor. On the other hand, you've got microalbuminuria, they're on an ACE inhibitor. If you're over the age of 55 and have, and you're a cigarette smoker, you've got lipidemia, some other cardiovascular risk factor, then an inhibitor is recommended. But it's not a blanket statement over the age of 55. You need to have something else on top of it to justify it. Right. So, and aiming for a dose of ramipril of 10 milligrams a day, perindopril 8 milligrams a day, shown in these landmark trials. And again, caution prior to conception. Women. Primary prevention, ASA, not recommended for most people. Definitely secondary prevention, but as a blanket statement for primary prevention, currently not recommended for people with diabetes. Any others before I drone on? This new as well, recommendation 7 with regards to the cardiovascular risk reduction. So I've already said that if you're not in your glycemic targets with metformin monotherapy along with diet, exercise, and weight loss, and you have established cardiovascular disease at baseline, then the drug in choice would either be empagliflozin or liraglutide or canagliflozin. And the thing that's different is that they say that drug, like empagliflozin, should be added as long as the GFR is over 30. Now that's quite a low GFR to be adding an SGLT2 inhibitor. The reason why they say that is that in the EMPA-REG study, they had a majority of people that had GFRs of less than 45, and certainly the cardiovascular benefit of empagliflozin was seen in people who had low GFRs. In fact, in the subgroup analysis, it would appear that people who had GFRs of less than 60 appeared to do better from a cardiovascular point of view than those people who had GFRs of over 60. So from a cardiovascular point of view, the SGLT2 inhibitors have been shown to be beneficial down to a GFR of 30. Now, you're not going to get much glucose lowering once the GFR is less than 45, but if you're not needing to have too much of a reduction in the glucose, but you're looking for the cardiovascular benefit, you can use empagliflozin, canagliflozin at a low GFR. The product monograph for empagliflozin was recently modified such that is indicated down to a GFR of 30 for empagliflozin. I don't believe canagliflozin has that official indication yet. Reasons for thinking about adding the flozin, like empagliflozin or canagliflozin, or well, sticking with those two, would be not only would you be reducing major cardiovascular events, but you would be reducing hospitalization for heart failure, and as well as slowing the progression of diabetic nephropathy. So if you're looking for a drug of second choice and you have any concerns about cardiovascular disease, heart failure, and/or nephropathy, then this drug class is an obvious thing to look at. With regards to the liraglutide or the GLP-1 agonist, again, major cardiovascular events were reduced with that agent, and it did reduce progression from micro to macroalbuminuria. It had no effect on heart failure hospitalization for the GLP-1s. All three are seen with the SGLT2 inhibitors, however. Exercise and healthy eating, of course. We should be recommending be active, minimum of 150 minutes of moderate to vigorous intensity aerobic exercise per week. That hasn't changed. And, offer the clinics and the primary care physicians tools on the website to help patients meet their physical activity goals, including prescriptions, so being more prescriptive in this regard to help people meet their physical activity goals. As far as nutritional management, I think there's a number of dietitians on the line, and I say something that's wrong because dietary aspects of care is not my strong point. Why don't open it up for the dietitians to chime in if they have any particular comments, if not questions about the nutritional aspects of this. I'm interested to hear what you have to say about it. Anybody? Are people recommending dietary patterns, specifically Mediterranean diets, DASH diets, vegetarian diets, very low glycemic index diets? What's happening out there?
Simone again from Cranbrook. I'm not so sure about recommending a particular diet, but we're seeing a lot of the ketosis diet being recommended by other healthcare professionals, and so we're just going to work with that and have a healthy diet.
Right. What about the ketogenic diets for people with diabetes?
So our thought process is anybody who comes in with a diet, then we try, because they're doing lifestyle changes, and so we try to just moderate a little bit and offer some carbs in there, because I believe that people with diabetes need carbs for energy and fuel consumption.
A very provocative study was recently published in the journal Pediatrics. It's not a journal that I usually read, but it came to my attention. This was there's a social network group online that promotes a very low carbohydrate diet for people living with type 1 diabetes, people on MDI and insulin pumps. And these researchers were interested in reach out to this social network community and, with their consent, filling out a questionnaire looking at how their perception of their own health was, what their glucose control was like with self-monitored blood glucose and A1Cs, and frequency of hypoglycemia and frequency of diabetic ketoacidosis. And the response was quite high. There was several hundred to perhaps 1,000 people responding to this particular questionnaire, and the results were interesting and surprising in that people generally had a good sense of their own health. There was minimum of hypoglycemia. There were very few cases of diabetic ketoacidosis. Many people were actually not telling their primary care physicians that they were on this very low-calorie ketogenic type diet for fear that they would be told off and discouraged from doing this. So they were sort of doing it on their own or with the support of these people on the social network. And it was this generating study that suggests that at the least, there should be a small randomized controlled trial done in type 1 diabetes with a very low carbohydrate diet. See, as in the short term, what are the effects, let alone what the long-term effects might be. Of course, when you're very low on carbs, you usually will be higher in fat, and whether that'll have a good or a bad effect on long-term outcomes is of course unknown. But at least it didn't seem to be harming people, and I thought that was interesting. We're certainly seeing, I'm a little bit weary about people using SGLT2 inhibitors and going on a ketogenic diet due to the fact that the drugs themselves are promoting increasing glucagon levels, promoting the tendency towards ketogenesis. Certainly in pregnancy, we're not recommending low carbohydrate diets due to fear of inducing insufficient fetal growth and brain development, that sort of thing. Yeah, I really leave the nutritional management to the experts, and I leave it to the dietitians to discuss with people. And of course, a diet's only as good as what the patient will follow through with, so it has to be individualized and be appropriate and all those things. Yep.
So I was just going to say, I find it a little bit frustrating, like the keto diets, just because I don't. There's a lot of patients are doing it, and a lot of good direction, and all I hear from dietitians who I talk to is no good. They need carbs, they need this. Yet I have people getting off of insulin who are doing keto diets. I have people losing lots of weight. I have people with way more energy, and they're getting more exercise. So it would be nice to have some more evidence and more direction around them, because people are doing them regardless. So
that's true. I mean, people are doing it.
And there are some people that so far have excellent results. So,
I think that's the issue is for dietitians, is that there's very little long-term data. So that's where we stumble, because we see dramatic results, but we don't actually we know that people who go on these diets often, I know we're talking in relation to blood sugar, but if they're losing weight, that they often will regain that weight within 3 to 5 years. And we do not have good long-term data, so it does make us a bit skeptical about advocating for these.
These short-term studies that are, there's not enough of them, but they are interesting. There's another one that was in the, it was published online in the Lancet at the beginning of this year, and I think it's been published in the actual journal itself, but it's certainly online. And there's a study out of Scotland and Northern England in which they took people with type 2 diabetes who had had their diagnosis for 6 years or less, and they randomized them to usual dietary management versus a very low caloric diet, so not specifically low carb, but very low calorie diet, which was I think somewhere between, I think it's around 800 calories a day, liquid meal replacement for 3 months, followed by additional 9 months of calorie-restricted solid food done through primary care physician offices throughout Scotland and Northern England, nurse practitioner-led patient interactions following a protocol, looking at remission of type 2 diabetes diagnosed or defined as A1C less than 6.5% on no therapy. The remission of type 2 diabetes in these people with early type 2 diabetes at 1 year was 48%. And the highest success, of course, were those people that lost 15% of their starting weight or more. So clearly, lose the the higher the rate of remission. Of course, that wouldn't work necessarily for somebody who's had their diabetes for 15 years. What's going to be the effect at 2 years? Well, they haven't published that yet, but that's coming. So they're following these people longer term. So I think you can do really good things in the short term with carb restriction and calorie restriction. What's sustainable, we'll see, but very little data. And of course, we know the results with bariatric surgery as well. Let's focus on what's new. Retinopathy, no changes from before. Well, we're near the end here, actually. What's new is you folks are probably all familiar with the SADMS routine, where if people are ill for other reasons and they're at risk of volume depletion due to poor oral intake, or they're vomiting, or they've got diarrhea, that you should temporarily hold medications, including sulfonylureas, ACE inhibitors, diuretics, metformin, ARBs, and steroidals. And the new thing to the SAD man, making plural, is the SGLT2 inhibitors to reduce the risk of euglycemic diabetic ketoacidosis. Foot care, I think I'll leave it at that because I'm running out of time. The last thing that I'll say, which is something that I haven't been doing over the years, is for people with diabetes at 40 years of age and older, getting a baseline EKG is recommended. Doing it every 3 to 5 years. Do it earlier if there's cardiovascular risk factors, and something that I haven't been doing. I think I've opened it up now for questions. We've only got 4 minutes.
Just a reminder to press #6 to unmute your line if you'd like to ask a question.
Maybe you could, Angela, or I'm interested in the article or the on how increased glucagon levels promotes ketosis. Just be really interested in reading more material on that.
Well, when we look at ketoacidosis, pathophysiology of the usual form of DKA is characterized by anybody who has absolute insulin deficiency and high glucagon. So the high glucagon to insulin ratio promotes ketogenesis. So the lack of insulin promotes lipolysis, and the high glucagon directs those that fatty acid breakdown into the ketone pathway. So it's, I'm not a biochemist, but it's basically it has to do with the insulin to glucagon ratio promoting ketone body formation. And the interesting thing about SGLT2 inhibitors is that when somebody with type 2 diabetes goes on SGLT2 inhibitors, that the glucagon levels actually go up, and that's why hepatic glucose production when you're on SGLT2 inhibitors also goes up, partially explaining that the A1C lowering with these drugs is less than you would expect for the amount of glucose that they're losing through the kidney, and the reason for that is because they're actually making more glucose from their liver. The net effect is that their blood sugars go down, but it's a net effect of losing glucose through the urine minus that which is increased in the liver. So it's a very interesting physiology there. I'll see if I can find something for you. If you could go through Angela, yeah.
Yeah, this is a great explanation. I think I get it now.
Anything else? I hope everybody had lunch, and perhaps we learned something too. That would be the idea behind this. But if there's no other questions, I'll thank everybody for their attention.
Thank Dr. Phillips for presenting today, and to all of you for taking the time during your lunch to join us. As mentioned, we have recorded this and the other Lunch and Learn sessions, and we'll be posting those shortly online for later access for anyone that may wish to listen again or have colleagues that were able to make today's session. We will send an email notification identifying where the recordings may be accessed once available. Thanks. Have a great day, everyone.
Thank you.
Thanks.